So good morning, and thank you to the ACS and the IOM's National Cancer Policy Forum for having this workshop. It's been a it's been an excellent workshop, hearing from cancer treatment through all the research that's being done in psychosocial research for the pediatric families. And we've heard some excellent presentations along the way. We are segueing into the next session where we're going to talk about some of the databases and resources that have been established in addition to all the research to try and capture endpoints and outcomes that we can't always capture within clinical trials. We have a couple of different presentations coming up today. I do want to follow up a little bit with a couple of my last comments. I also want to thank the families who have shared their stories, as well as Melinda, who has shared her personal story and personal journey. I think it's been insightful and helped us to all think about how important and how valuable this aspect is to the cancer care. So moving forward, I think we're going to start with Richard, who is going to talk about standardizations for data. We've talked about collecting data, lots of data, patients' data, family data, and data collection is almost always universally viewed in a positive way. I think one of the concerns and questions as we go forward is we can collect a lot of data. The questions really are, how can we integrate the data into study questions so that what we get out of what we put in is really meaningful and helpful to us all? So we'll start with Richard.
All right, so thank you very much, Laura, for the invitation, and for the other organizers for the wonderful conference. It's a real honor to be here at the National Academy, which I just learned a little while ago was chartered by Abraham Lincoln in 1863, and so it's a real honor to be speaking here, and also to the patients and families who spoke earlier today. It's very moving and I think motivating for us as clinicians to hear your perspective in ways that we don't when we're actually interacting with the families in a therapeutic setting. So I wanted to thank you for that. So the title of my slide in the program is fairly long and complicated, and I'm honestly not sure that I understand it. I think of it as just being, what can we do to make COG better from a data standpoint? That's my perspective. So as you probably know, and I'm probably, as Peter said, speaking to the choir here, or preaching to the choir, the Children's Oncology Group is the largest cooperative pediatric oncology group in the world, and it's really, in my opinion, and I think in the opinion of many people, responsible for the very substantial advances in pediatric cancer. And for AML, acute myeloid leukemia, which is what I study, the event-free survival has improved dramatically, although we still obviously have a very long way to go, really within the context of COG trials. And really, COG is the only organization that can randomize 1,000 kids to one of two treatments and decide which one is more effective. There's no other organization in the world that can capture that many children, and that's an incredibly powerful resource, I think. COG also defines the standard of care for kids not on protocol. So we know actually that 90% of kids in the US who have AML who are not treated on trials are treated with standard AML chemotherapy as per the COG backbone. And so that creates, I think, a uniformity of care that probably improves outcomes overall, and I think this is very different than some of the adult cancers. And finally, COG forms a fantastic platform for identifying and validating risk factors in these large sample sets. But there are things that I think we could do better in COG. One is we could monitor toxicities more efficiently, and we're very interested in that. And I think if we could identify costs and perform cost effectiveness analyses on our clinical trials, that would be meaningful. And then to integrate clinical epi and comparative effectiveness studies, I think would be very meaningful. And so we're going to give you, hopefully, examples in each of those areas. So our, I think, fundamental hypothesis is that if we take data from an external data source and integrate it into COG clinical trial data, that will give us a richer resource with which to answer these kinds of questions. And so we've really been focused using the Pediatric Health Information Systems database. So this is 46 freestanding pediatric hospitals across the United States that have approximately 5.5 million inpatient cases and 20 million ED visits, and have all the standard administrative data. So 123 million ICD-9 codes live in this data set. But what's more important is that it actually has resource billing data. So 350 million pharmacy bills and 320 million laboratory bills. And each of these bills, although it won't have the exact dose given of the medication, or it won't have the CBC result, generally speaking, it has the date that the bill was dropped. And so that lets us create a longitudinal set of resources that were used for each patient in our merged data set. And there's also a charge, so $330 billion of charges, which would be great if we could have on the COG side. And then there's 6 hospitals, actually, that report actual laboratory data, so the value of the CBC on this day, or the value of the blood gas, or the microbiology result, and also radiology results. So we merged COG and PHIS several years ago. This was approved first by Dr. Regimen, and Peter Adamson has been very supportive, and Malcolm at the NCI also. And then I think, very importantly, the PHIS people, Matt Hall and David Burtock, made this possible, and we owe them a great, in my opinion, great debt of thanks to being willing to put their data to use in this way. So this was a probabilistic merge, and it was performed at PHIS for data security reasons. And then the big question is, does the merged data set actually reflect the overall clinical trial? We got about 40% of the patients on the overall trial. And what you can see here, for the overall study population, you see the overall survival and event-free survivals by the 2 treatment randomized arms. And in our PHIS cohort, it's exactly the same, actually. So the point estimates are perfectly comparable. So we think we have a valid subpopulation that we have the PHIS data on. So then the first thing we wanted to do is think about, okay, well, now that we have this, can we make adverse event monitoring more efficient? And as you know, reporting of adverse events on clinical trials is an ethical imperative, and it's an important trial endpoint. And in COG, currently, the way it happens is that a data manager abstracts the medical record, identifies the adverse event, enters it into an RDE system, and then there's an email generated that goes to one of a couple of physicians who then evaluate that adverse event for grading. And so on the 0531 trial, there are actually 11,702 adverse events that were reported on 1,000 patients, which is an extraordinary amount of work done by all these data managers to capture this data. So we wanted to know, actually, can we do that more efficiently using electronic data? And we decided to focus on PHIS plus sites, where the sites are actually reporting the microbiology culture results. And the example I wanted to show you was for Veridan's group strep infections. So this is a life-threatening bloodstream infection, and actually 42% of patients on the 0531 had at least one VGS infection. And so we wanted to see, can we use the microbiology data that's available in these 6 PHIS plus sites to identify and report infections rather than manual review? And when we do that, actually, we find that the sensitivity is actually really good. 92% of the time, we actually find the infection in the PHIS data. And when we do find an infection, 97% of the time, it is actually an infection. And this is measured against chart abstraction. So we sent pediatric oncologists to, I think, 12 hospitals, abstracted charts on 180 patients. And so this is absolutely the gold standard. So this is, I think, very promising for us. And we're in the process of thinking about how to expand this to other laboratory values, and also how to expand this beyond the 6 PHIS plus sites. I will say that PHIS is expanding PHIS plus, so that as of next year, additional sites will be able to enter their laboratory data and then to evaluate their laboratory results against other sites. So we're also really interested in estimating treatment costs, and there wasn't previously a way to do this in an efficient setting. There's one prior COG trial that evaluated costs of asparaginase, but they had to do it through manual case report forms where people had to manually abstract data, and so we wanted to think of a much more efficient way to do that. So PHIS actually has adjusted inpatient cost data, because PHIS was actually created as a database by these pediatric hospitals to drive or to inform their planning, financial planning, and so there's actually cost data available in PHIS. And that cost data is adjusted for year of service and for the item and for geographic region, and it's available obviously in PHIS. So now we think, through this merge, we have a methodology for evaluating inpatient costs on COG trials. And so this is actually an overall assessment or an overall estimate of adjusted inpatient costs on the 0531 trial. This is on a per day basis. And I'd call your attention to a couple things. Actually, is this the pointer? Actually, the pointer? Arrow on top. Okay, sorry about that. So this right here are inpatient costs. These are room and board charges, which comprise about a little bit more than 50% of the per day charges. Pharmacy makes up about 25%, and then laboratory makes up a smaller fraction. So this is interesting as a descriptive thing, but what's really interesting, and the real question is, does it cost more to give the randomized study drug or not? And in the 0531 case, this was Mylotarg. And as you could see from the prior curves, and which I didn't discuss really fully, is that Mylotarg was associated with an improved event-free survival. And so then the question is, does it actually cost more to deliver Mylotarg in the on-protocol phase than to not? And the answer is actually it doesn't. So this is over here, standard chemotherapy costs on an average is $3,000 per day, and Mylotarg is $2,900 per day. And there's no difference that we could appreciate in the relative contribution of each of the cost drivers, that is room and board or pharmacy costs or other costs, to this. And then we also decided to look at adjusted cost by course, because we can now look to see how much does transplant cost, which is this very big section over here, versus how much does the first course of chemotherapy cost versus the second and versus the third. And what we saw, and this was actually really surprising to us, that there's some pretty dramatic differences here. We certainly expected transplant to be the most expensive because it has the longest associated inpatient stay, which is 43 days. But we really didn't expect that the most expensive cost would actually be in the fourth course of chemotherapy. I would have thought that that would have been an induction, where patients are the sickest when they come to us, but actually not. And so I think this is actually really relevant for us in our current trial, where we're now randomizing this fourth course of chemotherapy versus the second course of chemotherapy for patients who have high-risk disease. And so we, I think, are going to be able to make some decisions or sort of inform the community about what are the costs relative to differences, if there are any, in relapse rate or toxicity rates. And I think that hopefully will be value added to the broader community. And I would say that we didn't see any differences in cost by by race, by gender, or ethnicity. And we did see differences in cost as we would expect by age, where the youngest patients actually cost less than the oldest patients. And that's in part because the older patients just require more vials of medication, and so there's a cost driver there. So I wanted to talk a little bit about the third area, which is improving clinical epidemiology and comparative effectiveness studies. And we've been very interested for a period of time in disparities in AML. And it's unfortunate, but very consistent, that African Americans fare worse with AML therapy in COG trials. And that's been true over now 4 consecutive trials over about 15 years. And so we've been interested in trying to understand this. Now, there are obviously multiple drivers of what could be the differences in outcome by ethnicity. There could be differences in access to care or comorbidities, disease characteristics, or treatment response. And so what we wanted to do in the PHIS cohort is begin to look at, are African American patients sicker when they come to the hospital for their first admission? And if they are sicker, what proportion in the disparity does that actually explain? And so we did that by taking a cohort of patients with AML that we've built in PHIS, and this is actually separate from the COG-PHIS merge. And this is 1,143 patients that we've built out by manual review of their chemotherapy as well as their ICD-9 codes, and have about 950 Caucasians and 187 African Americans. And we evaluate induction mortality, which in AML is the chance of dying after the first 2 courses of chemotherapy, and incorporate into that a severity of illness measurement, which is, ICU resource utilization in the first 72 hours of their hospitalization. And so this is the patient characteristics of that cohort. And what was really surprising to us, but in retrospect maybe shouldn't have been surprising, is that the only significant difference is here in percentage of public and private insurance, where African Americans have a 50% rate of being publicly insured and a 25% rate of private insurance. And in Caucasians, it's almost the opposite, with a 46% rate of public insurance and a 37% rate of private insurance. And then when we looked at induction mortality, we found a significantly increased risk for African Americans to die in the first 2 courses. That is the definition period of induction. And that risk is about twofold. And I've broken it out here by induction 1 alone, which is just the first course of chemotherapy, and then in induction 1 and 2 brought together. And what's important is that these odd ratios go from 2.7 to 2.5 and 1.9 to 1.7 when we adjust for ICU resource utilization in the first 72 hours. And so based on these data, it seems to us that ICU care in the first 72 hours of the index admission explains about 40% of the excess relative induction mortality risk. And so for us, this is a really interesting and important point, because this isn't information that we could actually get from the COG trial. Because on the COG trial, we don't have information about how sick you are when you come to the hospital in a direct way. We know your initial white count, but that may or may not correlate with severity of illness. So we think this is an important component or an important ancillary piece of information that's going to help us begin to understand why this disparity exists. And then finally, we wanted to look at the interaction between insurance status and race in terms of induction mortality. And these are Kaplan-Meier curves, my apologies, describing how those 2 factors work together. And what was really surprising to us, but in retrospect perhaps should not have been, is that patients who are African American and are publicly insured have a dramatically different and a statistically different increased risk of induction mortality. So there's something about being African American and being publicly insured that together is different than being Caucasian and publicly insured, or being African American and being privately insured. And the odds ratio for being Black with public insurance is 4.5, so a really dramatic odds ratio. And again, this is something that we're able in part to capture in PHIS in a way that we couldn't entirely in the COG data because of the ICU resource utilization data that's available. So now that I've taken you on something of a whirlwind tour of a little bit of the work that we're doing, I wanted to close with a recommendation, or my personal recommendation, which is really that we work towards a comprehensive integrated data registry for children with cancer. And I think this really involves several things. The first is that this involves, I think, broadly engaging patients, families, the healthcare providers, the data holders, those of us who are researchers, regulatory agencies, and funding agencies for support, because there are a lot of risks and controversies around federating data in such a way. There are HIPAA issues, and people have very understandable privacy concerns and data use concerns. And this work only happened because Dr. Regimen and Dr. Adamson at COG were supportive, and the NCI was supportive, and PHIS decided to allow us to use their data. And we had spoken to another data provider that captures about 25% of all hospitalizations in the US, and they wanted $100,000 to tell us, before they would tell us whether they could merge or not, right? So, it's difficult to overstate the importance of everybody being willing to contribute data and to work out the regulatory and ethical processes and safeguards that need to exist for this sort of work to happen. And finally, and this is, I think, a way of thanking my research team, is that those of us who have access to this data need to do the studies and publish them that are meaningful and informative. And I think Lillian's point yesterday about the frequency of publication from clinical trials is a really good one. And so that I'm going to leave here my acknowledgments and just thank everybody who did all of the work to make this possible.